It's 2 a.m. You've just finished a long list when the pings you. A 45-year-old patient, severe generalized abdominal pain, guarding, and a high white cell count. The clinical question? Just 2 words. Acute abdomen. But acute abdomen isn't a diagnosis. It's a mystery, and in the next few minutes, we are the ones who have to solve it before the patient heads to the OR. Welcome to the race against time. When the pressure is on, you can't rely on luck. You need a system. I group my acute DD into 4, must not miss, buckets. In case of acute abdominal pain, my strategy is as follows. I have 4 sites first to be examined, which are the right upper quadrant to prove or exclude acute cholecystitis, left upper quadrant for gastric lesions, right lower quadrant mainly for acute cholecystitis, and finally to left lower quadrant for sigmoid diverticulitis. This is a single CT axial image with acute cholecystitis. Note is made of pericholecystic fluid, gallbladder wall thickening, and a gallstone in the gallbladder neck, as well as other non-obstructing calculi, findings that are consistent with acute cholecystitis. This is a single CT axial image of perforated gastric ulcer, revealed a focal luminal outpouching with surrounding fat stranding along the lesser curvature of the stomach. No free air or free fluid. CT axial image in the right lower quadrant revealed a subhepatic collection containing gas and appendicolith, in keeping with an appendicular abscess. CT axial image in the left lower quadrant revealed perforated sigmoid diverticulitis. If these 4 quadrants are free from lesions, my second step is screening the whole abdomen, searching for one of the following signs. I have a mnemonic for these signs, which is BIFI, which B correspond to bowel wall thickening, I for inflamed fat, F for free fluid or free air, and finally another I for ileus, in case of inflamed fat, which can points to the site of the lesion, while bowel thickening if seen in small bowel probably will be inflammation, while if it is in large bowel will be mostly tumors. The ileus could be obstructive or paralytic, while presence of free air or free fluid points towards perforation.
Contrast coronal CT images demonstrating prominent and increased mesenteric vascularity representing comb sign and small bowel wall inflammation at multiple levels suggestive of Crohn's disease. Diagram illustrates differences between the CT appearance of normal fat, fat stranding, peritoneal and/or fascial thickening, and free fluid. This smart art divides the ileus into 2 types. The first one is obstructive, which could be diagnosed by presence of parts of bowel dilated and the other parts are not dilated, as in volvulus, while the second one is paralytic type, which shows dilatation of all bowels, as in peritonitis. On CT there is evidence of an encapsulated fluid causing subacute bowel obstruction. The transition is seen at proximal ileal level. No abrupt transition seen. There is a large volume of free subdiaphragmatic gas with air fluid levels under both hemidiaphragms. Here's my pro tip. For the night, always look at the lung bases on an abdominal cort. I've seen residents spend 20 minutes hunting for an abdominal cause of pain, only to realize the patient has a massive lower lobe pneumonia. The acute abdomen can sometimes hide outside the abdomen. Mastering the DD of the acute abdomen is about speed and system. If you want to dive deeper into these specific cases, check out my Radiology Know-How playlist. Don't forget to subscribe to help us grow our AI radiology community. I'm Dr. Mohammed El Masri, and I'll see you on the next shift.